For the olfactory nerve, ensure nasal patency and have the patient close their eyes during testing. Bring test substances like coffee or peppermint to within 30 centimeters of each nostril separately. Assess visual acuity for far vision using the Snellen chart at a standard distance of 6 meters. Evaluate near vision with the Jaeger chart at 30 centimeters, where J1 to J4 represents the normal range. Perform the confrontation method at 1 meter to map visual fields, noting normal lateral extent is 100 degrees. During fundoscopy, identify the red reflex at 30 centimeters and evaluate the optic disc for papilledema. Grade papilledema from 1 to 5, where grade 5 indicates total obscuration of all disc vessels. Classify hypertensive retinopathy using the Keith-Wagena Barker system, noting AV nicking in group 2. For diabetic retinopathy, follow the 4-2-1 rule for severe nonproliferative stages, including venous beating. Examine the oculomotor, trochlear, and abducens nerves together by testing extraocular movements in all directions. Trace a broad H shape 60 centimeters from the face to isolate specific muscle functions. Distinguish ptosis causes by checking pupil size, where a small pupil suggests Horner's syndrome. In a third nerve palsy, the eye typically assumes a down and out position with a dilated pupil. Test the trigeminal nerve sensory divisions V1, V2, and V3 for touch and pain symmetry. Assess the motor component of CNV by palpating masseter and temporal muscles during jaw clenching. Evaluate the jaw jerk reflex, where an exaggerated response suggests a bilateral UMN lesion. Check the corneal reflex for the 5th nerve afferent and 7th nerve efferent limbs. Examine the facial nerve by observing for symmetry during frowning, smiling, and puffing the cheeks. Differentiate LMN palsy by Bell's phenomenon, where the eyeball rolls up during forced eye closure. Grade facial nerve dysfunction using the House Brackman scale from grade 1 to grade 6. Evaluate the vestibulocochlear nerve using a 512 Hz tuning fork for Rinn and Weber tests. During the caloric test, cold water at 30 degrees Celsius produces nystagmus to the opposite side. Assess the glossopharyngeal and vagus nerves by observing for symmetric elevation of the soft palate. Elicit the gag reflex, noting that a unilateral absence signifies a lower motor neuron lesion. Test the spinal accessory nerve by resisting shoulder shrugging and head turning against force. Observe the tongue for atrophy or fasciculations, and note any deviation toward the weak side. In conclusion, distinguishing between bulbar and pseudobulbar palsy is critical for localizing brainstem versus supranuclear lesions.